It has been so blissful to be at this hall at this time, and it's really very serene moment and a unique conference where science, service, and spirituality meets. I don't think anywhere in the world we have a unique conference like this. I was asked to talk about this difficult topic, but when I saw Dr. Jagat Narula walking in, he is the world-renowned expert on this very topic. So Jagat, I'm going to try to speak on a topic that you have worked very hard all your life, all the research, all the papers. So if there are any questions in the end, I will refer all these questions to you. Jagat Narula is my class, my alumni, my friend, my dear brother, and also our chief guest for the conference and keynote speaker tomorrow. So let me start with this. So let's see here. So the number one problem is how to detect a heart attack before that happens, and how to detect the disease in a South Asian before it strikes us. And this is $1 million, or rather I would say $1 billion question. And last 5 decades of research, intense research and experts and all the commentaries and all this, I've been asked to present in only 10 minutes. So let me give you a case presentation that sounds very personal to probably all of you, and it's not rare. It is unfortunately not that uncommon. This is a 45-year-old gentleman who actually was walking and jogging in a park near where I live in Pittsburgh. Very fit, very healthy person, but suddenly one day morning he collapsed and he was in cardiac arrest. He was taken immediately, life flighted to the hospital where I work. And of course, with the immediate availability of CPR and resuscitation, he was lucky. He was taken care of, taken to the cardiac cath lab. Of course, he had a typical ECG that you've seen multiple times, tombstone, anti-wall STEMI. And of course, I want to show the angiogram, if I can play with this. Oh, sorry. Just bear with me. This is an angiogram that you've seen. Right coronary artery looks good. The left antedescending artery, you can see a plaque that is ruptured, resulting into high-grade stenosis, responsible for the STEMI of the entry wall, and a state-of-the-art intervention. Stent was placed, TME3 flow was established, patient recovered uneventfully, conscious, went home. Then he came to see me a few days later, emotional, with the tears in his eyes, and asked me 3 questions. Okay, why this happened to me? How can I prevent my kids from happening to my kids like that? And what can I do to prevent this from again happening in the future? And those questions very pertinent. Now, when he came to me, he was a typical South Asian, Indian descent, living in America, which you can relate to a lot of people here. Every time you open the newspaper here, somebody's dying of a heart attack or sudden collapse, every week or every month. Same story, same phenotype, but different places and different karmic burden. But if you look at the story, it's very familiar. His blood pressure is borderline. His BMI is also borderline. Low HDL, which is typical of South Asian dyslipidemia. And if you use the AHA, American Heart Guidelines flowchart, basically he does not qualify for statin because it falls into the low risk category. Less than 5% is a low risk. No statin, just a discussion. So that measure, but he somehow got some advice from some Indian cardiologist. He got his calcium score, which was 0. And again, coming back to your question that was asked, how come calcium score can miss a lot of soft plaque? Yes. So he was missed multiple times. He had a stress test by company physical, which was also remarkable. So the question is, what went wrong? What went wrong here? Well, what went wrong here is that this conventional systems of scoring, the way we calculate, way we kind of estimate the likelihood is the flawed approach. The new approach is that we have to look at the disease and treat it. So that's a paradigm shift. That was one big misstep in his life that we have to pay attention to. That is the answer to the question that you were asking. So a lot of these people who fall into low-risk category of South Asian descent, they do not get statins, and the people trained in America, primary care physicians, do not want to order a calcium score because they follow the guidelines. But South Asian race is a race against time, and if you have diabetes, if a family history, then you definitely have to further stratify the risk by calcium score to start with. But the question is calcium score enough? Of course, calcium score is a major development, has been accepted in the guidelines for right population for intermediate risk, especially for South Asians. I order and I advise everybody to get a calcium score for South Asian descent. But even then, there's a detection gap. And a lot of scores have come over the years. We had a Framingham score, then we had PCE, pooled cohort equation, that we used to calculate. Then recently, American Association has come up with a PREVENT score. But actually, the best way to detect coronary atherosclerosis, especially in subclinical state, is to see it and to treat it. Seeing is believing. Just like anything else, we have a breast cancer, we get the mammogram. We have a lung cancer screening, we get a low-dose CT scan. Why not do a heart CT scan as a screening in a population level as the first modality so we don't miss the disease, no matter how the disease is arrived? It's a metabolic or genetic, epigenetic or LPA, whatever is causing it. If there's a plaque, that will be the surest sign. So you see the disease, you treat that. That is the first lesson I want you to take home, especially the practitioners and the students and the researchers and the fellows in these hospitals. Now the next question is that what plaque? I'm sure you heard about the plaque, has a soft plaque and a fibrofatty plaque. We studied this classification in the pathology slides, but this is a model of John Rumberger. And this is a famous model that he put it out as a model of the tip of the iceberg. And this model reminds the Titanic accident because when you don't see, you get hurt. So what you see here only is the calcium. And when you see the calcium score, that is based on this, but 80% of the disease is not seen. It's below the surface, and that hit the Titanic. Remember the Titanic story because they did not see this, and the divers got hit and they got flooded. So 80% of the disease is a soft plaque, which is made of the fibrofatty plaque, not calcified plaque that is not visible. And that is the story of many of the people who got calcium score, which is 0, and you still go on to have an acute coronary syndrome. Now, there are some studies which have shown, this is an iconic trial, and it's shown that 2/3 of the people who have acute coronary syndrome actually come from a non-obstructive, non-calcified plaque. So think about the predictive value, very poor predictive value. This is another study, Miami Heart Study, which showed that people, even with a 0 calcium score, have a 16% chance of having a soft plaque. So 0 calcium score is a good screening tool, don't misunderstand me, at a population level, but it is a flawed in a person who has a family history, who has a high-risk features, has a diabetes, and is already in the highest percentile of the risk. Maybe coronary CTA should be the best approach, even though we know that the large randomized outcome trials are pending, but it's not a class 1 indication. But for personal precision therapy, one can make a case for coronary CTA. When you do the coronary CTA, if you look at the ROC, the ROC is the best when you combine risk factors and calcium score. At the same time, when you add coronary CTA, your ROC is the best. So can we do better? Yes, in some patient population, especially the high risk, people who have a premature coronary disease, people with inflammation, people with diabetes, I think the first modality, even in asymptomatic person, could be the coronary CTA. And this is the story of 50 years, starting from 80s autopsy findings when they found out the real culprit of acute coronary syndrome is not so much the stenosis, but the plaque rupture. And from that onwards, the terminology of the plaque rupture, and Dr. Narula and Dr. Valentine Fuster and a lot of the leading thought leaders have studied this phenomenon over the years. So it started in the 80s by autopsy, and then later on became the vulnerable plaque or unstable plaque that has a thin cap, also has a lipid pool, necrotic core called a TICFA. thin cap fiber atheroma. TIC4 is our nemesis, and that was responsible for majority of the plaque rupture and acute coronary syndrome. And then there came coronary calcium and CTA. CTA has additional value because it not only quantifies the plaque, but also tells the morphology, the physiology, the biology, and also in some newer data, inflammation. The coronary CTA is your one-stop shopping. So even though this is not a class 1 indication, but in some situations, I think coronary CTA is a far superior test and replaces and supplants the coronary calcium score. And in coronary CTA also, there are high-risk features. You can have a remodeling indication. You can have a low attenuation plaque that Dr. Prasad mentioned. You can also have a peri-inflammation, and you can also have a spotty calcification. You have a napkin ring. So there are some features in coronary CTA that already identifies person at a higher risk, and that makes you think about more aggressive treatment. And also you can track the disease. You can follow your coronary CTA. So if you want to go from population to personal level, coronary CTA is the modality of the choice. Now you can study the plaque by invasive techniques, by OCT, optical coherence tomography, or IVUS, or even infrared. There are many things we used to do, and we still do, to define the plaque better, but those are invasive tests. They take time, they're risky, not cost-effective, and not applicable to every general population. But coronary CTA, comparing non-invasive versus invasive, I think the first modality of choice for population that is the highest risk for coronary disease. Now here, just to show you that the story of the unstable plaque became vulnerable plaque, then became a vulnerable patient. Now we are focusing on the patient because the patient is angry and inflamed and thamasic, according to spiritual terminology. Of course, everything is going to be inflamed. He will have multiple plaques, multiple heart attacks. So coming from that, now the definition of high-risk plaque has been broadened, and the new statement recently, last February, they include not only plaque rupture, but plaque erosion. Plaque erosion, another culprit pathology that is responsible for acute coronary syndromes, lately more so, especially in females, and also a eruption of the calcified nodules. So all three pathways, plaque rupture, plaque erosion, and the eruption of the calcified nodules, are combinedly called a high-risk plaque. And that is a standard new statement and position on the high-risk plaque. And so the question is, can you trust the coronary CTA to look into the high-risk features, which are much more comprehensively studied and seen with the OCT or the IVUS or even infrared spectroscopy? There is a study for Mass Journal that shows there is a correlation, not perfect correlation, that you can see all those features that you see invasively also on the coronary CTA for all practical purposes. So basically, what I'm trying to say to you, that coronary calcium score is a good test to start. It stratifies the patient, reclassifies the patient, gives you a number to follow, has the best negative predictive value. But if you really want concern individually, in the age of precision and personalized approach, if you have a high risk, if you have a family history, then try to get a coronary CTA and follow, because coronary CTA is a one-stop shopping. With all the advancement in the coronary CTA now, we have FIR, physiology, biology, pathology, and he said it's a panvasculitis, inflammation, low attenuation index, and also inflammation around the vessel wall. And that is your gold map. That's the CCTV. Coronary CTA is a CCTV of your body. You can follow it, you can look at it, it will motivate you in terms of lifestyle, you can track it down, and you can is your life score. So the question is, next paradigm that is changing is that, remember the primary and secondary classification? Now, if you have a plaque, you already secondary classification. Your focus should not be after the event. Your focus should be before the event. So there is a period of about 10, 15 years where the plaque will grow rapidly before the rupture. So that period is the golden period to intervene. So all the therapies, all the interventions, all the lifestyle modification that we should focus right at the beginning, when the plaque starts to develop and starts to grow, not when it erupts like a volcano. So this is paradigm shift also, because the prevention of the coronary disease should be in subclinical atherosclerotic stage when it produces the biggest progression. And of course, what do you do then? Once you find out the plaque, which is unstable plaque, that is angry plaque, that has the high-risk features, you see it in CTA, then what can you do? There are two approaches. One is a lifestyle approach that I don't want to go into because of shortage of time. Everybody's talking about lifestyle. But the most important thing, I think, where the most of the value you get from your buck of the bunny is about statins. And the statins have been shown, high-dose statins to bring your LDL down. I don't have a time to go into details in the studies, but the lower the LDL, the better it is. My score is 68, and I take Lipitor 80 milligram, and my LDL is 32. And I'm telling you because this is the time you can really regress to some degree, but at least stabilize or modify or even prevent the progression. So the plaque cannot go away. You cannot dissolve the plaque. You can do plaque stabilization, plaque modification, create a new phenotype which is less inflamed, and you lose your necrotic core and lipid. All you have is thick cap. You modify the plaque becomes unstable to stable, less likely to rupture, and that is the progress, and that is a positive outcome in itself. So all the trials have been shown, and there's no lower limit to the LDL. The lower, the better. Nowadays, you can use PCSK9 if you have a problem with statins. Even ezetimibe is shown to show the regression. The niacin and the fibrates do not show, but all the statin or non-statin lowering therapies have been shown to show the plaque regression, reduce the inflammation, and all these pleiotropic properties are very important. So one thing most important, and the lifestyle is good too, but the most important thing we can do ourselves is to go up. When I go to the clinics and volunteer in India, the primary care doctor prescribes a Lipitor 10, and that's it. And we don't know what the target is. There's no education. We need to really bring it down as much as possible because that is the most important prevention. I'm an interventional cardiologist, board certified, but the best intervention is prevention. So that is number one message I want you to take home. Statin, take the LDL, Lipitor, Crestor, whatever. Bring it down as low as possible, even in primary prevention. Secondary prevention is everybody understands. And then don't stop there. Don't stop there. As Dr. Prasad said, we only reduce the risk by about 40%. There's still 60% residual risk. What do you do about that? Then you go to the next pathway, which is anti-inflammatory. Anti-inflammatory diet, which I believe a little bit. I have my own cocktail that I use every day. I don't have time to go into that. But these trials that were, Colcotrial and Cantos trial, they are there. They are not widespread and applicable yet. We need more studies, but there is a role based on the CRP that inflammation, you can bring it down. Then you can try to use the anti-platelet therapies, low-dose anticoagulations, and of course, nowadays, GLP-1, SGLT2 have been shown also as a secondary anti-atherosclerotic properties. So don't stop there just because statins, PCSK9, and even LPA lowering medication. There are 2-3 new medications for LPA coming. Every Indian or everybody should get a LPA for once in a lifetime. That is one thing also missing in the practice of cardiology here in the United States. It should be standard LPA for everybody. So get your LPA testing, get your LDL, do everything to bring it down. Statins have a problem, myalgia, then go to PCSK9, use ezetimibe, and even use EPA. And Dr. Bhatt did the trial evaporate and showed some regression, 10% or so. So even that all, that specified, refined EPA can reduce their inflammation. And of course, the next thing is your plaque passivation. So plaque modification, plaque stabilization, plaque regression, and the plaque passivation is putting a stent, and that's a new horizon where you see a vulnerable, unstable, high-risk plaque, and you put a stent in. There are some data, some trials going on, but that will be something difficult to accept as a standard of care. So to prevent a heart attack, detect the plaque, and it's important to find out the plaque that matters. Calcification is there, it's a surrogate marker, but that will not give you a heart attack. The heart attack will come from a soft plaque that you may have missed on a coronary calcium score. And how you treat that? Lifestyle, medications, and of course, ultimately, plaque passivations. I stop here. Thank you. If any questions, we have a world-renowned expert, Dr. Narula, you can ask him, or I'm happy to answer any questions on coronary calcium score or coronary CTA as a primary prevention modality in South Asian or anywhere, primary prevention. Thank you.
In the interest of time, yes. I think.
Yes, sir. Okay, the triggering of the plaque is a shear force. And there are multiple components. We don't know exactly, but I think Dr. Jivanand showed that slide, or somebody showed, or Dr. Venkatram showed that slide, that coarctation of aorta, and you don't have a atheroma, and just beyond the narrowing, there's atheroma. So the shear force, because of the thin cap, and because the shear force and hemodynamic changes, I think that ruptures the plaque, and macrophage and metalloprotein protease, the thin, narrow angle where there's turbulence, and that ruptures the plaque. So it's a combination of biological and hemodynamic factors. Jagat, you have anything to add?
Excuse me, Sairam sir. I have a question. Are there any clear-cut studies done after the statin usage? The coronary artery disease is very much reduced. What are the, pardon me for the ignorance. I just want to know what is the percentage of reduction in the coronary artery disease after the usage of these statins?
So what happens when you take, now this is another interesting finding. When you take the statins, actually the plaque calcifies. So paradoxically, your calcium score may go up. But this is how it works. It will stabilize the plaque. But in terms of overall picture, 1% reduction in the plaque volume in the coronary CTA will cause 20% reduction in the adverse cardiac event. 1% reduction in the plaque atheroma in the coronary CTA will translate into 20% less risk for adverse cardiac events. Or 1 millimole of cholesterol will lead to the 25%. So there is a big dividend to be gained. Every time you drop the pressure, reduction of stroke, every time you drop the number of your cholesterol, very, very big dividend. It's worth following, worth pursuing, and worth being aggressive. So that is the best investment. Bring your LDL down. Now, we know about the HDL, we know about the triglyceride, the stories keep changing, but there is one molecule which can help us to prevent a heart attack in terms of statin therapy is the LDL. Our goal should be to bring the LDL down. All other will fall in line, the LPAs and triglycerides and HDL. But best thing is to take the statin and bring it down as low as possible and make sure your plaque regresses or stabilizes to the degree you don't run the risk of a heart attack at this young age.
I think there's another question.
Sairam sir, you were just mentioning you take an early morning cocktail or a concoction to lower down the LDL. Would love to know more about that.
What is that?
So you're just mentioning something that you take something, concoction or something in the morning or a cocktail to lower the cholesterol LDL. You were mentioning in your
Sorry,
lines.
ma'am, I'm not able to understand what.
Okay, you were mentioning something, a cocktail or a concoction?
Cocktail, yeah, the cocktail was the diet I was talking about.
Yeah, would love to know more about that.
That is most potent anti-inflammatory diet is a plant-based diet. So I was telling that, I'm a vegan, so that is a good thing to start right there. There are a lot of articles about anti-inflammatory diet, which are proven, evidence-based.
Absolutely,
yeah.
Yes.
Turmeric is one of them, though there are data and controversial because the mercury, a lot of people have taken out of it, but there are a lot of compounds in our natural diet in Ayurveda that I believe, based on the evidence, that are very important in causing reduction the inflammation. And that inflammation, not only for the heart, for the brain too. The heart health, the heart is good, the brain is good. Heart health and brain health are operating from the same risk factors. If you have a good heart, you have a good brain.
Got it.
Yeah.
Thank you, sir.